my team led a randomized trial that was also performed at Kaiser Permanente, Washington, that showed that offering individuals who were due for cervical cancer screening mailed HPV self-testing kits, increased cervical cancer screening, and also led to cost savings per each additional exam, because pelvic exams and well exams cost some money. And so after the study was over, Kaiser Permanente Washington decided to adopt the program. And in addition to mailing kits to patients that were at average risk for cervical cancer and age 30 to 64, they wanted to also implement self-testing at the point of care in clinic, either at the time of a well exam or at the time of any visit, if they were due or overdue for screening, which was different than the study. It was before the FDA approval, because the study had gotten clearance for the lab to do the study by mail. So we were able to do it before the FDA clearance. With the rollout of the program, they wanted our learning health system, which we have a group of researchers that work with the delivery system on evaluating and helping with programs that this is the health organization does to improve care, in this case, preventive care. So our group worked with the leaders to evaluate the program. And what we found overall, we did a 6-month evaluation a few months after the program had started formally, and compared it to 6 months before the program. Both evaluation periods were after COVID, the COVID pandemic shutdowns, and pretty much we were back to care as usual. And in that 6-month post period compared to the pre period, we found that cervical cancer screening increased by 2.2%. It included 40,000 individuals due or overdue for cervical cancer screening that were at average risk, which is a large population. But there was what we call a voltage drop, and we investigated why. Why did that happen? And the factors we found was that rolling out is not exactly like research. We have a high fidelity in mailing to everyone in our study sample. In the denominator, everybody gets the mail kit. When they rolled it out, that was not the case. So they wanted to make sure the lab was not overwhelmed with too many results and too many positive results for colposcopies. And so they initially just rolled it out to individuals that were coming due, and they put a hold on those that were overdue, who definitely needed to be screened. And they did not realize that the programming continued on during that 6-month period. And so that was one of the things that we uncovered with our evaluation. And then after our evaluation, they made them up. But we did look at, of those people that were mailed, about 12.5% were actually mailed kits, that about 25% of people returned them. So actually people were very responsive. It's just not everyone got the mail kit. Almost as many people that completed the mail kit completed kits in clinic. And then overall, with that increase, we had an increase in screening of about, I think it was almost 2,000 more people screened in that 6-month period, which is a lot, that you'd take that over a whole year. It's a lot more. And pelvic exams actually decreased. It was only 1/3 was done by self-testing. And we also previously evaluated whether patients liked it in the study. And yes, there was high acceptability of the kits. Evaluation, we didn't want to reevaluate that, so we evaluated clinician acceptability, physicians, obstetrician gynecologists, nurse practitioners, and physician assistants. We mainly talked to leaders, and we were mostly physicians, and then we made site visits and talked to the entire staff at 3 sites. And what we found that it was highly acceptable to the clinicians. They were mainly primary care. And because they felt they could use the time. It's not like their time gets used, but access is an issue. And they could address other issues that might be important to the patient. And it could alleviate the burden of the pelvic exam, which for many individuals is difficult, or they don't want done by a male physician, and or they have reasons to avoid it because of disabilities, prior trauma, gender identification, and other issues. So from that point of view, the clinicians perceived it as highly acceptable to the patients. But there were challenges. Clinicians weren't always aware of how accurate it was. And it is actually in studies and in meta-analysis as accurate as HPV collected by a physician. And they're both an excellent test and more sensitive than the pap smear in if an individual actually has precancerous changes in the cervix, it's more likely to find them than a pap smear. But the clinicians did not know that, and sometimes thought the pap was better, which the pap is more specific, but it doesn't find everyone. And so most people don't have HPV, and about 90%. And adding the pap smear, other studies have shown, doesn't benefit much if you don't have HPV. Almost all cancers caused by HPV carcinogenic strains.